So the decision to stop the bortezomib and just continue with lenalidomide and dexamethasone often comes up, particularly in patients who are not transplant eligible. They generally get tired of coming in for their bortezomib shots. There's different ways of giving the treatment. You can give it more frequently at full strength, which is twice a week for 2 weeks out of 3, which is particularly inconvenient, or the less aggressive once a week type of treatment, either 3 weeks out of 4 or even every week. So people tend to do it differently. But ultimately, patients in many cases get tired of coming in. And so even though I think it's preferable to continue a treatment that's working for as long as it's working, and that would be my general recommendation, I also typically will not continue the bortezomib because of the inconvenience of it. I work in a place in Los Angeles hard to get to, so patients just arriving for their treatment, it's challenging. So it's just for many reasons I can't do it. Other patients have no problem. I've had people take bortezomib weekly for 7 years. So it can be done, it's just patients don't prefer it in reality. In a patient with high-risk cytogenetics, it's particularly important to continue the proteasome inhibitor. A lot of these high-risk cytogenetics were determined to be high risk based upon the drugs that we had 15, 20 years ago, which were certainly 20 years ago, did not include proteasome inhibitors. So the proteasome inhibitors seem to negate many of the high-risk features if they're used, and often work just as well as a therapy in patients with high-risk disease as they do for people with standard risk disease. So when somebody does have these high-risk features, it's even more of an argument to continue with the proteasome inhibitor. Use of a proteasome inhibitor in somebody with high-risk disease is important. I certainly am fine continuing the bortezomib if patients are willing to come. Often what's done is, for convenience sake, it's given at less than full strength. So people often compare proteasome inhibitors based upon full strength versus full strength, but in reality, patients often don't take full strength bortezomib indefinitely, and for that matter, carfilzomib indefinitely. One certain advantage of ixazomib is that swallowing a pill once a week, 3 weeks out of 4, is very convenient. And so patients often can take full strength proteasome inhibition, at least with that medication, and continue on full strength of that drug. So I do tend to offer patients ixazomib after they've received the VRD regimen as a way of continuing triplet therapy in a more convenient fashion. One of the key terms that is used frequently in multiple myeloma is the use of maintenance therapy. Patients love the word maintenance. They like the word remission. Myeloma is a disease that we don't think we can cure, or certainly we don't seem to cure it very often. So I think there's been too much excitement or labeling of a drug, things as being maintenance. I think maintenance sometimes means and is implied less therapy. And if a patient is taking treatment and it's working and it's being tolerated, then I think they should continue that therapy at the doses that were working. So I try to avoid the use of maintenance, the term, because it sounds like and I don't diminish the doses of the drug just for the sake of diminishing the treatment. I only reduce the intensity of the treatment based on side effects, and some patients don't have side effects despite full strengths of these drugs.